Hi there, this is Kathy Widener. You may know me better as KMC, and I'm very happy to be able to introduce this topic. As you may know, throughout this year, we have done our courtesy webinar to the profession on kind of some 101 topics, and this is the one that's going to wrap us up on documentation. Absolutely our favorite thing, of course, but you're getting to hear from a real expert and a great teacher. So I'd like to introduce Dr. Colleen Auchenbach, who is our Director of Education here at KMC University. Maybe some of you have been lucky enough to have coached with her, but she's going to present some really exciting stuff today. So Colleen, I'll let you take it away and give you as much time as we can do here.
Awesome. Thank you, Kathy. I am always excited to talk about documentation, and it is quite difficult to squish it all into an hour, but I think you're going to enjoy what I put together here for you. We're going to cover some basic overview and actually look at a few notes as well, so should be a good time. And as Kathy mentioned, please feel free to type in those questions or ask them at the end. We love questions. So this is just our disclaimer. These are my views and opinions. I do not set any practice standards, and we are just here to educate and inform based on what we know right now, today, to be true. Everything that we talk about, as all of our members know, is always backed by resource. Our outcomes, outline, etc. today is going to be just a basic overview of documentation requirements. We're going to touch on a few specifics that are kind of no-brainers, but we still see all the time in notes. We're going to also look at medical necessity that can not be not talked about in this arena. And then we're going to do an overview of these different types of visits and how to tie everything together. One of the first things that we need to establish is, why are we even documenting to begin with, and what does a good documentation capture? We are always trying to put into written record the encounter between the patient and the doctor, so that there is, for multiple reasons, a written record of what's happening in that office. So it creates an entire record of the lifetime of the patient in your office with a timeline. We're supporting medical necessity. It absolutely enhances quality of patient care when we're documenting to the standards that we'll talk about today. We're protecting ourselves as well by having an encounter, actual recording of the encounter. And you have to document to be able to submit for reimbursement. Not only that, but we've got license requirements that tell us we have to document as healthcare providers. So all of these things are the just baseline, why we're doing documentation, and these are signs of when we have a good documentation. The basics that we see and coach about documentation have to do with these three things: abbreviations, legibility, and signatures. In notes, whenever we're using any kind of abbreviations, we've got to make sure that they are standard abbreviations. And the reason that is because we don't ever want an auditor to stop and say, what's that? We always want our notes to be written in such a way that it is clear to read through what is going on with this patient. So when we do our own abbreviations, it's not necessarily wrong, but it does give pause to somebody who maybe is not familiar with chiropractic, because chiropractors are not always the first person that's looking at a note in a records request situation. So the more that you can lean towards the standard abbreviations, the better. And if you do or are using your own abbreviations, you absolutely need to create a legend or a key that should be submitted anytime you are sending in records anywhere. Legibility is vitally important. This is a deniable issue. If an auditor cannot read your notes or a payer cannot read your notes, they are well within their right to deny. How can they know what you're trying to say if they can't even read it? So you've got to use ink. You've got to be legible. If you're going to make a correction, don't erase. Don't try to cover it up, old school white out. Just put a line through and make your edit if you need to. And we know that you can read them, but, auditors can't. And that is really the point, is what's in there. What you're trying to say. What your little marks mean. But if somebody else cannot easily pick that up and read it, then we need to clean that up. So legibility is huge, as is signatures. Medicare requires that we sign our notes in a particular way. And one of the things that we're going to give you today in your free downloads is the actual document that is highlighted here about Medicare signature requirements. So knowing the rules is important. Knowing what your software setup is important, because a lot of times what we'll see is an insufficient signature, but we've never asked, do we have the capability to do a signature in the way that we are supposed to? And what is that signature supposed to look like? That it should have the doctor name, the credentials, and a date and time stamp. That's the best. That is what we're going for. The services that are provided in any encounter need to be authenticated by the treating provider. And you can absolutely do hand or electronic, but stamped signatures are not acceptable, and that is still true. So in that document that you're going to see, it now is starting to talk about things like scribe and AI, and what you're going to see is that it mentions the doctor has to be the one that oversigns everything. So in regards to timely documentation, which is when am I supposed to sign my note to make it timely, what we see Medicare saying is that they expect that note to be generated at the time of service or shortly thereafter. And there is a window of time where you can delay that entry for a particular reason. This should not be the matter of course. This should not be the routine. The routine should be, I'm doing the note, I'm signing the note at the time of the encounter. But if something is happening that's making me have to delay that a little bit, they give room for that 24 to 48 hour window for it to be signed. And that is per their own resources, which this one comes from Chapter 12 in the Medicare Claims Processing Manual. And we'll see another manual a little bit later on. So important to know where all these rules come from. We're not just saying them. They are actual written down rules from Medicare and other providers. So signing your notes in a timely fashion is vitally important. If it is outside of that and the payer has a rule, that is another deniable thing. So if I can't read your notes, if they're not signed in a timely manner, it doesn't even matter what else is in them. They could be denied and you're paying back money. And we don't ever want that. That's why we want to start with these basic concepts that, if these are things that you're thinking, oh my gosh, I'm not really getting that done. These are easy things to put on a list to get going, because really you can't submit a claim until your note is fully documented. It actually, says that on the claim forms, that you are saying when you send those that it's fully documented and signed off on. So if your notes aren't done, if they're not signed, those services are essentially unbillable at that point. Here are a few of the things that we see in electronic documentation that are marks of bad documentation, put you, on the naughty list, so to speak. And those are those non-standard abbreviations. We see that informed consent is not being documented, which doesn't necessarily mean that it's not being done, but it's not being documented, and that's a problem. If you're referring out and not documenting it, that can be an issue with electronic records, as well as no outcome assessments, missing certain components of SOAP or the daily visit, and we're going to go over those in a little bit, or if everything looks the same. That can happen easily in electronic records. Copy, 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 they all look the same, and we're not actually putting a note together for the specific encounter with that patient for that day. We also see paper records that have things that are not right and that are red flags, so to speak. It's perfectly acceptable for you to do paper records. Nothing says that you can't do that, but they still have to be compliant. So if you're not using a pen, again, if we can't read them, same thing with the abbreviations. We see this a lot more on the paper records. No signatures or dates, things aren't filled out, just looks like it's not complete. And unfortunately, missing that patient identifying information on each page is a problem. And I say all of these things, and some of you may be thinking, well, none of that still happens, but it does. It absolutely does still happen. We look at a lot of notes, we work with a lot of offices, and these things all are still currently happening. So if you are, again, if you're noticing any of these things that I'm going through, start a list, because these are easy things to fix that will immediately up your game when it comes to just basic documentation rules.
Dr. Colleen,
yes.
We're getting a couple questions on the signature. I wonder if you could address
Sure.
when they use e-sign to sign a note before it's completed, is the double signature a problem?
Well, I would have questions back to that, as you probably would expect, Kathy, which is, why are you signing it before it's completed?
Yes.
The best thing, and this is on this slide right here, is signing the note is the last step. And everything has to be authenticated by the doctor. So my coaching question back would be, why would there even be that system in place where we're not just signing it at the end?
Yeah, we'll keep an eye for that. Go ahead.
Okay. So again, patient name and date needs to be on each page of the chart, whether electronic or paper. It doesn't matter. The patient name and date, back in the day, it would be, if I drop the folder and the papers go flying across the room, how am I going to know whose goes with what chart? I realize that a lot of things are digital now, and that's essentially not an issue, but what if it is? What if a loose, PDF or something gets put into the wrong folder? We've got HIPAA to contend with in the electronic sense. We've got to just have all of our ducks in a row. So patient name and date of service on each page. If the CA completes any part of the treatment, that's got to be indicated in that section of the note where the treatment is being done or documented. And the treating provider is responsible for last look at the documentation to support the services that are being billed, because their number is the thing that is being billed under, and they are the ones that are signing that claim form. So signing the notes, the last step. Again, doctor has to oversign and authenticate everything. Documentation is a legal document, so we have to handle it as such. The life cycle of this patient's record that I was talking about before is going to include all of these pieces listed here. It's going to be for the whole time that patient is in your office. We're going to have different sections of the record. We're going to have, the history of the patient as that progresses. We're going to have all the treatments that were performed, rationales for any therapies. Any maintenance care should be well defined. Anytime we're starting a new episode should be well defined, and really just anything that relates to how you are managing their health as their provider in your office. This is all part of the patient record. Inside of that whole historical record, this is what Medicare and other payers are expecting to see. They're expecting to see episodes where we are, just like this picture shows, starting with a history, moving into an exam, a treatment plan, daily visits, a re-eval, and a discharge, and closing that loop on every episode. So there should be sections within the historical record of your patient that look like this, like an episode, like a package or a chapter in the story. And they should be well defined by the things that we're going to talk about for our initial visit, our treatment plan, our diagnosis, how is the patient following our orders. These are the things that are the little pieces that should be within that full historical data. For each episode then, we need to be considering what does it take to establish medical necessity. So we are needing to take all of these pieces that you see and put them together. History and exam are the inputs. We're gathering data there. What is the patient telling me? What am I finding out from looking at them? We're taking those and putting them together and deciding things. Assessment, diagnosis, and treatment plan comes from the doctor decision making. So our staff cannot help us with these pieces. They may be able to help us with the history and exam, absolutely, but the decision needs piece of the doctor brain needs to be doing the outputs of assessment, diagnosis, and treatment. And then you can see these all go together to establish medical necessity. I get questions all the time about, well, if I just do this one thing over here, then that's going to be enough, right? No, there is never just one thing. It's all the things together for each area of complaint that we are trying to say is medically necessary and bill as such. All of our care is clinically appropriate. No one is questioning that. We know that you are all wonderful doctors taking care of your patients. Within all of that care, there is more well-defined medical necessity. There's medically necessary care per third-party payer definition and then per managed care. And you know, Medicare is that smallest little bubble. They only ever pay for spinal CMT when it's active treatment because it's medically necessary. So that's the, you know, narrowest scope there. But all of this falls within what you're doing. We just need to know how to better define what can we bill that's medically necessary, and then what are the rules for our contracted payers and what are the rules for Medicare. So no, all care is not medically necessary. Clinically appropriate is the care that you see listed here. Our maintenance, our wellness, our supportive, our chiropractic care is all clinically appropriate. But we have to, within that care, look at where are the acute problems that have functional deficits? Where are the chronic problems that are aggravated and now have a functional deficit that I know I'm going to be able to improve? And what is the definition per each carrier for what they consider to be medically necessary? For Medicare, they are very clear that medical necessity is when a patient has a significant health problem. It's in the form of a neuromusculoskeletal condition that needs to be treated, and the manipulative services must have a direct therapeutic relationship to the patient's condition and provide reasonable expectation of recovery or improvement of function. This ties so many things together that we talk about all the time. There has to be a complaint. There has to be a misalignment, subluxation, segmental dysfunction. There's got to be a diagnosis, and there's got to be a functional deficit. And all those things have to tie together. They have to be what's called causally related. So the complaint, the exam, the diagnosis, the assessment, the treatment plan needs to be almost in a, if you think about it, like a linear line. Neck complaint, neck exam, neck diagnosis, neck treatment. And it seems silly to say it that directly, but that is what these payers are telling us. So if there's no complaint, but we're going to treat an area, that's not going to be covered per these definitions. If there is a compensatory area that we want to address, that's okay. We can do that. And as full spine adjusters, we have to understand the difference between what is medically necessary and what is clinically appropriate within spinal regions. So if we take 5 spinal regions, they are not all going to be medically necessary, right? There's going to be maybe 1 of them or 2 of them or 3 of them, and that's that smaller bubble in this picture. So you may adjust all 5 regions, but you may not be able to bill all 5 regions because they're not all medically necessary. They don't fall in that direct causal relationship per the definition for what medical necessity is. When it does, then we want you to document that and bill it that way. When it doesn't, then we're not going to count that when we're counting for our CMT code. So the opposite of all of that we can bill because it's medically necessary is what Medicare defines as maintenance therapy. And you can see this is per Chapter 15 in the Medicare Benefit Policy Manual, which has a lot of our chiropractic rules in it. So that's a really good resource for you to go look at. This definition is a treatment plan that seeks to prevent disease, promote health, and prolong and enhance the quality of life. And is that not exactly what we are all trying to do as chiropractors? So this idea right here is where a lot of us stumble in, well, my care is this and it should be paid, but this is not payable. This is chiropractic, it's not payable. Medical necessity is the only thing that we can bill and expect to be paid for, as long as it's supported in our documentation. So this is what we expect to see within that life cycle of the patient in your office, and that we're recording all of these things in their notes and in their record, is they're moving in and out of active treatment. They've got an episode of care and then they're done, and then they're into wellness, maintenance, supportive care, and then something happens and we're back in active. It should flow like this and look like this. We should be able to see this in the notes. Doctor has to decide. It's up to the provider to decide if it's medically necessary or not. It's based on what you're seeing clinically, not a money decision. It's not that. It is, what are you actually seeing with this patient? So now let's kind of look at Medicare documentation guidelines for the different types of visit. And we're going to break these down. We've got initial visit, we've got subsequent visit. Similar, right? But our initial visit has a treatment plan, super important. And our subsequent visits are documenting what we're doing with the patient. So initial visit is going to be foundational. Subsequent visits are going to be more, here I am applying this treatment plan to the patient and this is how it's going. We find these to be the not so easy things that doctors trip up on. And it really is that initial visit. Not capturing the history in a way that makes sense, not having an exam that follows what we're doing. Treatment plan is huge. Missing treatment plans a lot of the time, especially related to capturing the function that we're trying to look for in the notes. And then the easier stuff seems to be those daily treatment soap notes, although these can be a problem as well, especially if we don't have that initial visit treatment plan as a foundation. And you know, the maintenance wellness treatments are easier as well because we're not having to meet medical necessity for those, but we do still need to be aware that there are state and federal standards that have to be met. So documentation tells the story of the patient, and we are writing for a certain audience. Our audience and who we are documenting for is not only the patient and ourselves, but we're being a good doctor, we're meeting our state minimum documentation, we're managing risk with what we write, and then we've got to code based on what's documented, and we can only bill for what's medically necessary. So being a good doctor, protecting your license, having liability considerations, and then lowering risk based on medical necessity and what can be coded and billed appropriately. Each initial visit is that foundational piece. So we've got to have these looking different than the daily visits. The initial is the anchor to that whole episode of care wheel that we showed you. And this is just in a different picture. History, exam, assessment, diagnosis, and treatment plan. That's an initial visit. History is where doctor's listening. We're taking the intake, we're taking the consult information, we're asking questions about what happened, because some of our patients aren't very forthcoming and we've got to kind of dig a little bit. And then we're reviewing each complaint. We need the history of present illness, the what happened, and the functional deficits for each complaint. We've also, as part of the history, got our review of systems, our past family social, and then we're starting to think about what are we going to do with the exam and the diagnosis. That's all beginning with history. For exam on an initial visit, what we're doing is we're following what we just found out in history. So each thing we just found out has meaning. Now what are we going to do to quantify that in our exam? And then what we find in our exam then is going to go support what we're going to recommend in our treatment plan. So you can see that causal relationship goes all the way through, right? Even into assessment. Assessment is one of the outputs from the inputs we just got. It's more than just a diagnosis code set. It has to do with how we're case managing and what we're thinking about this patient. Here's a great example of what an initial office visit assessment should look like. I've diagnosed Fred with an acute uncomplicated injury from his slip and fall. He has no known risks that would complicate his recovery, and there's low risk from gentle conservative chiropractic care. Now, if any of you have worked with me, you know that that first little piece there is going to help support our medical decision making for our EM coding. The next piece, we're talking about complicating factors and contraindications to care. There are none. So we're thinking about that, we're considering that, and we're writing it down. And then the last piece is we're saying that we expect Fred to do well with this treatment plan and not have any trouble. This is the doctor thinking about the condition we're going to treat Fred for and how we think that he is going to respond to care. So this is a great breakdown of what an initial office visit assessment should look like. Then, in addition, we've got our diagnosis codes. And the diagnosis codes is as specific as possible. How can we define what we just found out about Fred using the code and the descriptors that we have available? And if we need to add information to understand or to have somebody else understand why we're picking those codes, that would be what we call the written diagnosis, where you can write that out in your note and then put the most appropriate diagnosis codes, and that will help to drive the treatment plan and the treatment goals. So we have to stop and think. Remember, we're doing outputs, right? Assessment, diagnosis, and now we're going into treatment plan. They're taking that information from our history exam. We've got our diagnosis now. Now what are we going to do about it? What's our plan for getting this patient back to where they were before the mechanism of injury or the something happened? And that's the treatment plan. Every episode has to have a plan. And this is the beginning of the episode of care. This is where we're going to talk about a new patient starting or an established patient starting again because something new happened. And it doesn't matter how long this treatment plan is. When you're starting a treatment plan, you've got to have a plan. Medicare requires that we do these things in our treatment plan. We need to have a start date. We need to say frequency and duration. We've got to have specific, measurable, functional goals that are patient specific. And then treatment effectiveness, using something like outcome assessment tools so that we can show progress. And then using that onset date or date of current illness to indicate this is a new episode. So that's that box 14 on the claim form. These are your parameters for how we're going to take care of this patient. We're defining it with our treatment plan. When we go to look at writing goals, because this is an area that we see lacking all the time, you want to just really be patient specific, something that the patient is telling you they can't do. We're gonna make it measurable, and then we're gonna set it out as a short-term goal and a long-term goal. So maybe 30 days short-term goal, end of the treatment plan, long-term goal. And it should look something like this. Mary will sleep for 4 hours without interruption by 3/4, short-term. Long-term, Mary will sleep for 8 hours without interruption by 5:15, which is her level of function prior to this slip and fall incident. And that is an awesome detail right there. If you start doing that on your long-term goals, you are going to be far ahead of the pack, because that's amazing. That's what we're trying to do, is get the patient back to where they were before the medically necessary episode started. You need to also list in your treatment plan the recommended services with rationale for each one. So this is another place that's missing a lot of times. So either we don't have a treatment plan, or we've got a little bit of one, or we don't have functional goals, or we don't have rationale for why we're doing what we're doing with the patient. This is kind of, think about your treatment plan as your roadmap or your recipe for how you're going to get that patient better, how you're going to restore that functional deficit that they've got for the complaint areas. And a treatment plan is different than a treatment. It looks like this, all the things that we've just talked about, defining out the next course of care that we're going to provide to the patient. Here is a treatment plan in written form. This is what a good treatment plan looks like. You can see that it's a plan. It's not just a 3 times a week for 2 weeks. There's parameters here. I am defining what I'm going to do with this patient for the next 2 months and how I'm going to measure their progress. You can kind of think about it as those 5 things: start and end date, frequency, duration, short and long-term functional goals, recommended services with rationale, and then outcome assessment tool to measure effectiveness. These are the things that you should be putting into the initial office visit treatment plan. And then we take that and we go apply it to the patient and track how they're doing with what our plan was for them. This is different than treatment. So if you on an initial visit are also treating, you have to have a separate indication of that treatment. Here's what I also did to the patient today. So I did this whole initial office visit, which falls under evaluation and management service. And now I'm also going to do a treatment to him. We want to say technique, what's being treated, what therapies or modalities, specifics with those, for how long. This is the tracking piece that I'm talking about. So we make the plan and then we execute the plan. And that helps to make medical necessity clear. You always are going to code based on what you've documented. So it helps to make that coding clear too. And then we've got our goals to be able to track. All right, I've got some notes here that we're going to audit together. So we're just going to go through quickly an initial office visit and point out some things that we would point out as auditors to give you an idea of what we're looking at. So this is an initial office visit, and this very first section of the note says history, which is great, and then gives us some information about this patient is new. They've got a left anterior thigh problem. It started on March 10th when the patient was stretching, and then the next day it got tight and restricted. The patient can't lay down or lift up their leg. Walking's become difficult, walking slower. Did some cleaning and made it worse. Okay, this is a fairly good start. We've got some functional language here. We've got a complaint area. There's some good stuff here. But if we go into the next section of the note, we can see that now, immediately, we are telling a different story. Our chief complaint is talking about the back and the buttock area. And we're saying we don't know what happened. And this is immediately counter to what we just said in the paragraph above it. So an auditor is going to stop right there and say, what is happening? Which of these is true? What are we talking about? This is where we've got to know how to use our software better, okay? In the previous care section, we're saying that physical therapy was received, but we don't know when or what the results were. And that's an important distinction to make. Anytime there's previous care, you want to put those detailed parameters around there to separate you from whatever they had done before. And we've got some kind of diagnostic testing, but we don't know what the result was or even where it was. So details are important in the history. Similar, we've got a systems review, which is awesome, but we're just generally saying arthritis, and we don't really know what that means, and that needs to be defined. Past family social history, we've got some good stuff here. There's a surgery, it was in the 80s. All right, but then what else do we need to know about that? Because we maybe are going to want to treat that area, right? Our complaint area is close to that. Might want some more information about that. Same thing with the fire truck accident. We've got a date, but we don't really know what the result of that was and if there's anything lingering that we need to know about clinically about this patient to do our good doctoring piece of making sure that it's okay to give them a treatment. When we move into the exam section of the note, which is great, we've got good headings, history and exam, we obviously forgot, some data here, which is just part of that EHR system, and it sticks out like a sore thumb, just like if you're doing paper and there's blanks. So the other thing that we have here on this one is an abnormal finding that is never discussed as to what we're going to do about it, and that's a liability consideration. This doctor did do a good job of putting some additional detail into the range of motion, which is awesome. If you have additional detail about any of the testing that you're doing, putting it in here helps to show progress later. So does all measures. So anywhere you can measure your findings and put that in your note, that's great for showing progress later. This particular note is completely missing segmental restriction findings. We are not covering part with this note. The wording in here is kind of all squished together, and we've got all the same findings for all the same areas, and they're all moderate degree, and that makes it really difficult to show progress later. The other piece of this is we're putting in our initial visit assessment section into the wrong section, which at least there's something here about that expectation from the doctor. But if we go to the next page, now we're incorrectly using our EHR again and using a daily assessment that's just completely inappropriate for an initial visit. In the diagnosis, we've got pelvis and other low back pain, which lines up, but then we've also added some thoracic pain, cervical pain, and there are no complaints in that area. So that's an issue. So you can see that congruency, direct therapeutic relationship is important, and we can spot it when we look at the whole note. This treatment plan is immediately a problem. It will only be valid for this one date because we're starting it and ending it. So if we treat prior or after this, we are outside of a treatment plan, and that's deniable. And then we've got issue with saying where we've adjusted, where we don't have diagnosis codes, and missing specifics about what does this 30 mean down here. This is the today's treatment piece that I was speaking to, where we've got to separate out the plan and the today's treatment. And in this one, we've got that there's a pelvis adjustment, but we don't have any pelvic restriction findings. So this is very easily deniable from everything that we're seeing here. We've got another comment about an x-ray, but we still don't really know anything about it. And then we've just fully repeated a treatment plan that does not need to be there. Doctors, if you're talking to your patients and answering clinical questions and then putting that type of language into the note, protect yourself and say what those questions and answers were. It's important that we don't just put these like general statements in there without specifics. You want to have this record be a record to, you know, protect you as well if there ever is an issue. And lastly, we've got some medical decision-making guidelines that were used, but we're not clear how they were used, and really we're coding based on those, not so much documenting based on those. Let's quickly go through some routine office visit SOAP notes and what we want to see there. SOAP is a different format than initial. You could see in initial, our headings that we used were history, exam, assessment, diagnosis, treatment plan. Now we're going to go into a routine office visit or a daily visit. We're going to use SOAP format. This is the piece where we're just tracking that treatment plan we created. So subjective is, what is the patient telling you about how they're doing? Objective is, what are you finding? What are your findings? Assessment is, how do you think the patient's doing based on S&O? And then plan is, what are you doing to them today? Subjective needs to be for each area of complaint. We see very often that we're just squishing a whole bunch of complaint areas into one little blurb and then making a couple details about them. You can't do that. Separate them out with details for each. It should be very clear that this is a complaint area and here's a separate complaint area. Because obviously complaint areas are going to respond differently, so you've got to be able to talk about that. Make sure you're separating out your complaints. Make sure that in the subjective, we're asking the patient how they're doing since their last visit based on that function that we've defined in our initial treatment plan for goals. So here's a good example. The patient reports cervical pain, and then we've got some particulars about it. The patient's now able to sleep 7 to 8 hours at night. Awesome. The next little example here is that the patient has some decreased sharp low back pain, and we're putting in, you know, some numbers to that, which is awesome. And it didn't hurt to ride my bike here. Fantastic. These are the functional pieces that need to be in that subjective section of the daily note. So here's another example of what that looks like. Having a visit count is important for showing where we're at in the treatment plan. So visit number 5 of 20 in this case. And then you can see here, this is what I'm talking about with separating out the complaints and then having details about each one. So this is what we want that subjective section of your note to look like. Always talking about function. For the objective piece, which is the doctor findings, that should follow the area of complaint. We should talk about any measurable changes since the previous visit, less restrictions, increased range of motion, less muscle tension, whatever the changes that you're feeling on the patient. And then we've also got to consider that we're documenting support for what's going to be treated. This is where we really want to lean into PART. And this should be apparent on the initial visit as well in the musculoskeletal findings. But in your daily visit, this is a great way to show your objective findings is by using PART. PART is the physical exam requirement by Medicare to show where the subluxation or segmental dysfunction is. You have to document either an A or an R as one finding. That's where you are showing where the restriction or the misalignment is. And then you have to have a second finding that can be any of these other things. This is our best recommendation for your daily visits for objective, because now I'm following the complaint, direct relationship, right? And then I'm doing the treatment. The treatment then should be supported by those objective findings, restrictions, muscle findings, soft tissue findings, all of that should be apparent, just like we see here. So this is an example of the objective section of a daily visit. You can see all of the PART components. You can see all the soft tissues. And in this example, we're also showing where you can point out the difference between primary and compensatory segments for billing based on medical necessity, like I was talking about earlier with full spine coding. And that takes us up to assessment. Assessment, this is a piece that's really hard for Dr. Brains. This is where you are showing in the notes how the patient is improving and why you think, or how they're not improving and why you think that. This should be the doctor thinking piece. It does not have to be extensive, but it should not be canned. If you are putting every single time the patient is improving as expected, every single visit, that is deniable. You're not showing patient progress. It should be the patient is better, and I'm saying that because they're walking further without pain. They have less restriction in their lumbar spine. It should be the how they're going with the treatment plan you gave them and why you think that. That's what we're trying to do here with assessment. So really, you know, this is a muscle that needs to be flexed by all of us to do better on our daily visit assessments. Something like this would be appropriate for maybe a second visit. In the early phase of treatment, progress is expected. There was some slight worsening of pain, but that's within normal limits. Remember, this is your doctor thinking. I'm thinking that's within normal limits and should subside as treatment continues. Now, next visit, we might have something different to say about that, right? Now the patient's better, or now the patient's worse, and now I'm going to, what am I going to do? Maybe I'm going to send them for a test. These are the things that we need to be seeing in the notes. Plan is the last one. So SOAP, P is what did you do to them? What services did you do? Where did you do them? What are the specific settings for the treatments that you're doing? For any modalities, any therapies? What is the time? What are the services being provided? Details, details, details. Specific segments, specific muscle groups, technique. All of these things are so important because then we take that and we code it properly, and then we bill it properly. So documentation is so foundational to all of these things. And this is what this can look like in your note. Is here's the primary treatment with diversified to these areas. We've got some compensatory areas, like we said before, and here's our therapies that we're doing. Of course, all of these examples for a date of service would be signed by the doctor. All right, all of this becomes that page in the chapter of the story. So your initial visit becomes a page, your daily visit becomes a page, and then we're really documenting that correctly for what's happening with the patient. Be careful with salting. Salting is one of those things that can be such an awesome time saver, but if you are not using it correctly, you could end up with a whole episode that all the notes look the same, and that, again, would be denied by an auditor. So let's quickly just go through this routine office visit example. We've got just some general information that could be much more specific. We've got all our complaints kind of squished together, and then we're saying we're using a verbal or a visual. Well, which one is it? Just decide and say which one it is, okay? We're also saying there's no additional concerns, but then when we go here to objective, we now have some additional findings. And if you remember on the initial, we had additional diagnosis. Now we've got additional findings, but we still don't have any complaints in these areas. So this is just very incongruent from initial to daily, and these are the things that auditors are looking for. We're not hitting part on this objective, and we're just salting forward this initial visit assessment there on that bottom paragraph. The daily assessment, not too bad. This could fly for like one time. You know, but we wouldn't want to see this every single visit that the patient's coming in. And then we're copying over the treatment plan, which does not need to be on a daily visit. It's the foundational anchor piece for the initial. It doesn't need to be on the daily. The daily is what did we do? And in this case, we adjusted pelvis, T4, and C6. And this would be denied. It would just be denied because we don't have any pelvis findings. We don't have any thoracic complaints. We don't have any cervical complaints. So unfortunately, this doctor would get a not good finding letter. The last thing that we would do in an episode is go ahead and discharge the patient. when we're ready to release from active care because the patient is meeting their goals and their outcome assessment scores are better, we're going to transition them to maintenance care and out of active care. And we're going to decide when that happens. The doctor decides, now we're done and we're moving you into maintenance care. The other things that could happen here is if you want to refer them out, or if somebody is not being compliant with their treatment plan. These are the types of things that can happen in this space as well, which you would still want to do some kind of a discharge for that. This doesn't have to happen just on the end of your treatment plan. It could happen earlier, or you could get to the end and still see that there's some improvement that could be made, and then we're going to maybe have another little treatment plan for some therapeutic withdrawal type stuff. So really, it is the doctor, again, deciding when to put a pin in it. So based on that input data and the clinical decision-making from the doctor, when is this episode over and we're transitioning into that maintenance care? We really want you to always strive to document well for all your patients. One of my favorite things that Kathy says is just be more compliant next year than you are today. I also would encourage you to just create more compliant notes tomorrow than you do today. Take one of these things and improve them, and then take the next thing and improve them. And then if you get all those basic pieces in place, everything else will just come after that. So that is my presentation on documentation basics, and I am happy to answer any questions if we have any.
Oh, do we? We've had a bunch, and I've been answering them along the way and trying to reply to everyone so everyone can get a chance to look at it.
Oh,
there
good.
was an additional question about billing a Medicare patient properly with joint restriction in the lumbar but pain only in cervical, and the billing pieces. Maybe you might like to elaborate on that quickly, and then I can look at some other ones here too.
Yeah, so that's going to fall back to that definition from Medicare of the direct therapeutic relationship, and that it has to be like there have the best way I can get this idea across is Medicare and third-party payers do not think like chiropractors do. They do not understand that the body works all together or doesn't work all together. It has to be a very linear line between complaint area, findings, diagnosis, and what's being treated. They don't allow for the idea that if you adjust something in the lower body, it could affect the upper body, or vice versa. If you adjust the upper body, it could affect the lower body. It has to be direct. Neck, cervical, cervical, cervical. So there's no way to compliantly bill for the scenario that you just presented. That would be considered maintenance, because that's the word they use, and it would be considered patient self-pay.
Yeah. And of course we get the question, well, can I charge the patient for that extra area? We're just going to say, just say no.
No.
You don't want to do that.
There's no way to break apart that CPT code. That's a spinal CMT code. There's no way to just pull it apart into different sections. Different than I'm going to adjust the spine, it's medically necessary, and then I've got an extra spinal that's not. I could charge that to the patient. That's a different code. So just kind of think about, like, I can't pull that code apart. It's all together, and I'm just only counting for what's medically necessary.
Right. I'll let you answer this one while I'm looking at some others. Is it okay to charge a Medicare patient Medicare fees, I'm assuming allowed fees or limiting fee, when transitioning into maintenance care? And I'm going to presume we mean original Medicare here, so I'll let you take that one.
Yeah, so what does your ABN say for Medicare Part B when you transition them to maintenance? you can either continue to follow your Medicare fee schedule, or you can charge your full office fee.
Right.
It's the same across the board. And again, we're talking about Medicare Part B.
That's right. Can't say Medicare anymore, can we?
Nope.
This is an interesting one. I'll let you go ahead and field this one. If a lumbar complaint, can you bill 98941 if you're also adjusting the lower thoracic, lumbar, and pelvis, say T12, L5, S1? Or do you have to have thoracic complaint for any thoracic segments? That's a very interesting question that we do field quite often, isn't it?
Yeah, I like that one because it brings in the idea of what are you telling me in your notes? Are you tying that all together in a way that makes sense, that the complaint area is blah, and then my findings are here, and then I've got a diagnosis, and then I can say that all three of those regions are medically necessary. So if that is the case and you are saying that in the note and supporting that in the note, then that is absolutely possible.
Yeah. Because, how are you going to delineate between T12 and L1 really in a complaint? Yeah. Right, you can't.
Even more tricky is lumbar, sacrum, pelvis, right?
Sure, yeah.
Of course it could. Just like cervical and upper thoracic could be, for sure.
That's right. James would like you to elaborate a little more on the difference in determining medical necessity between therapeutic exercises and therapeutic activities. Always a fun one.
Come to my webinar in December.
That's right. Yeah, we actually are going to be doing a webinar just on those exercise codes that's being run through Chiropractic. Yep.
So therapeutic exercise is 97110. Therapeutic activity is 97530. Both of those are one-on-one constant attendance, timed code, minimum 8 minutes. It's got to be done by somebody with some skill. There has to be support in the treatment plan with very well-defined functional deficit and functional goals. And the expectation of the therapeutic activity is even higher, that it is so well defined why you are saying that that's what you're doing, because that code means that I'm not just doing an exercise to improve strength or something that we think about that we're doing with our patients all the time with therapeutic exercise, but that code is really has to be more defined into some kind of an actual activity, like helping the patient be able to get out of their chair or transition from their bed to their chair, things like that. So those codes definitely have a higher level of expectation of documentation to be able to call them medically necessary. And of course, they have to follow all the other things we said about the complaint area and the findings and the diagnosis.
And the gospel, according to Kathy, is when why are you beating your head against the wall for that code, which is really a physical therapy code meant originally for transfers and people learning how to use a wheelchair, etc. When your 97110 pays the same basically, and you have less hassle. But that's just me. I know you'd love this one, so I'll leave this for you. How long can a patient go without a visit before we need to reevaluate or do a formal re-exam, I think is what the doctor's asking.
Well, what is your office policy in your component program? So, that's a big question. We would have to have some conversation around it, but there's no defined timeline. I think usually what's being asked is, can I continue this episode if the patient's gone for 2 weeks? That's a lot of times what will be being asked. If a patient's out of your office for an extended amount of time and they're coming back in, are they coming back in because there's a new episode? Then you're going to do a new exam. Are they coming back in because they're just there for their maintenance visit? Then maybe not. So there's a lot of particulars to that question.
Yeah, agreed. And I think also the other thing around that reminds me of, reevaluations are not required unless they're listed in a medical review policy, because so much of that can be encompassed within your CMT. So what Colleen's talking about with your policy, how do you manage that? Now, remember, reevaluations are very different from specifically the outcomes tools that have to be done every 30 days. And on this slide, we just want to make sure that those that are not members understand you should not be using this email address. It should be the info. Yes.
This one's for members, and it's part of being a member with us is our help desk, which is awesome. So that's why I put this in here. When you are a member with us, you have access to our help desk, which is an amazing benefit of being a member. And we do have an offer today. If you would like to sign up to become a member with us, if you sign up for our annual library membership, we're offering a free proactive chart review to go along with that. So like how you saw a kind of a live audit of a note, you could have your chart looked at and get feedback from one of our auditors that, you know, would be very beneficial for you to know where to focus on your own notes. So if you're not a member and you would like to sign up to become a member, use this QR code, sign up for our annual library membership, and we will happily do a free proactive chart review for you to give you some direction on where your issues may be. And then we would also give you, you know, training links in our website of incredible resources where you can go learn and improve using our training tools.
And I would just add before we close out here, if you have an interest there, just pop something in the question or the chat and someone will reach back out to you. And, you know, if you don't care about it being free, we do also sell this service. And it's very, very popular because we're looking at your notes in real time talking about you. It's not theoretical, which I think is great.
Yes.
Well, Colleen, that was fantastic. It was an awful lot of stuff. If you are a library member and have an interest in the proactive chart review, ping us as well. We have something special for you as well. So please reach out and take care of that. A reminder, if you're a member, this will be listed in the webinar section of your dashboard. If not, you're going to receive an email that has a link back to where the recording is, which will be good for 2 weeks, and also the number of free downloads that Dr. Colleen has offered you. And Colleen, I made an executive decision and added in our abbreviations list because we had a lot of questions on that, and I thought that would be a nice gift for Thanksgiving gift for our members.
Great idea.
For our not members, but our everybody who's been here.
Our everybody, all of our members of chiropractic profession, they're all our members.
Right.
Because we're
that is right.
Don't forget, we have this last little thing for our new Help Desk podcast too. So if you like podcasts, make sure you listen to what we've got out there, and there will be more to come in this space as well, which is exciting.
Yes, wherever you get your podcast, Spotify or Apple or whatever it is, and then like and subscribe. You'll know when they're new. All right, we're going to close out. Thank you for being here so much. We're so grateful for you. And in this month of Thanksgiving, we want you to know that we're grateful for 18 years of being in business when we know that every business doesn't make it nearly that long, and it's because of you and because of our passion for helping the profession. So thank you, and we are grateful for you especially. And I'm grateful for you, Dr. Colleen.
I'm grateful for you too, Kathy. Thank you.
Yay. All righty. Bye-bye, everybody.